manifest themselves in various ways. Next slide, please. The research for bias, this is not all the research there is, but there is considerable evidence out there that this is a legitimate issue, and that we should be spending more time looking at it, particularly in medicine, because we do and will experience it one way or another. Next slide, please. So I think the thing to say is that bias in medicine, in terms of my talking points, they're present in everyone to varying degrees, and they can largely be denied both by the medical provider and a patient, or it could be a situation where you have a faculty member or administrator that is involved in some kind of bias incident of some kind. But biases are pervasive. They're both part of both clinical practice and research. And unfortunately, many health professionals remain unclear about how biases actually do have some effect on their work. Next slide, please. So I just a personal example, non-clinical example. When I grew up as a child, my mother was great at creating sweet potato pies. So I love sweet potato pies, particularly around the holidays. So they don't appreciate my weight problem though, but nonetheless, I do like them. And I was in a grocery store with my wife, and there was a woman actually selling sweet potato pies. She had a stand there, she was selling sweet potatoes. These were pies that she had made. And so my wife beckoned me over to taste the pies that she was selling. And I said, I don't need to taste the pies that she's selling, because she looks like someone who knows how to make sweet potato pies. And now that might sound like a compliment, but in other words, in my own way of thinking, this woman had all of what I would consider, at least internally, unconsciously, all the earmarkings for someone who could make good sweet potato pies. In fact, they were excellent sweet potato pies. We still buy them from her. But that's an example of a bias. I used to work in Alaska, and one of the things that I was told before I started working in Alaska was that there are all kinds of problems with people that have drunks, basically. And the very first time that I had that in the back of my head as I started working in Alaska, and my very first trip to Juneau, it was early in the morning, about 7 o'clock, and these two women just sort of stumbled out of a bar. I was walking down the inlet there and downtown, and one of them they were stumbling down the street, kind of supporting each other as they're walking down the street. And they looked as if they were going to, and this is a large sidewalk, that they were going to walk into me. And so as they were walking, I'm trying to move as far as I can to the curb to try to avoid this woman, but it's obvious that they're sort of stumbling their way towards me. In my mind, I'm thinking, okay, these people are going to hit me somehow or do some kind of harm to me. And so I instinctively, reflexively sort of reverted to this sort of mode, again, a bias, based on the information that I had, that these individuals needed to be warned, which I did do in that moment, to kind of caution them to just essentially stay away from me. I'm probably sure, knowing me, I used some more direct language that I would normally not use under certain circumstances. But again, those are examples of biases. Next slide, please. So how can these things come up in your clinical work or with patients? So you've got a patient who presents with issues associated with their family and work stress because they have outspoken political views. And this is something that can happen as you come in contact with patients. The patient also can be someone who embeds very strong religious justification for their political views as you're providing care for that patient. Next slide, please, Samuel. The patient's strong political, religious, cultural views are the exact opposite of you as a provider, but you're sitting there listening to this stuff as the person spewing this information. And what if the patient asks you as the provider for their take on some particular political, religious, or cultural views? So bias can have a lot of different effects on what we do and how we do what we do. Next slide, Samuel. So the question that you have to ask yourself, is it in the best interest of the patient to share your perceptions of their religious, political, cultural views? The short answer is not only no, but hell no. And ethically, is it appropriate for the provider to share their religious, political, cultural views with the patient? That also is a definite no response. Next slide, please, Samuel. So I wanted to give you something that happens in my work with veterans, and I will have people come in and will ask me, or say things like, I don't want to see any of these foreign doctors. This has come up before, and goes on to elaborate their experiences to justify their position. Or during the election season, did you vote for, and then they would go on and express their views about whoever person they voted for or didn't vote for. I always find it interesting because I hear people coming at me with these remarks as if I am aligned with their view of whatever political party that they might have. These things could have an impact on how care is provided, because you may be rather annoyed by a particular political candidate. At least I will have to admit that I am. So that's something to consider. So next slide, please. I wanted to share this slide here that kind of looks at the bias roles in both micro and macroaggressions. And the macroaggressions are basically are insults or other verbal, physical, sometimes acts that are taken where an individual is directing some type of criticism based on some characteristic upon which someone can be discriminated on. And so I used to have an old colleague who was president of APA that once told me that everyone, and I believe this, everyone has at least one characteristic that they can be discriminated on. And so this model, I think, helps you kind of understand some of the dynamics of what's occurring. In it, you've got a target, and that's the individual or individuals who are the focus of this bias or this micro or macro aggression. And then you have the perpetrator, and this is the individual who is essentially initiating the bias or displaying the bias or conveying some unwanted remark to the target. And on certain circumstances, you might even have an observer or a witness. And this is the person who basically sees what's going on and has obviously some impressions about the experience. And so when you look at these situations, it's important to try to identify what role might you be playing. And I think we probably have all been in one or more of these roles at various times. And they also explain, we don't have enough time to go into this today, but things that a person might do when they are either the target, or they're the perpetrator, or the observer or witness under those circumstances. I wanted to share, and I didn't put this in the regular PowerPoint, but I did want to share it with you, a situation that came up recently, and I was so shocked by this situation, but it's a good example of, not a good example, but a bad example of what happens with respect to medical students and other people when they're exposed to biases. And I'll just read you some of the notes that I had from this encounter. A medical student presented a quality improvement poster at a conference, and one of the judges approached her after the presentation. He asked her, how does she identify herself racially, which was not at all related to the topic of her presentation. Now, she responded, I'm a person of color, and I find that helpful when I'm working with immigrant populations. I had to be really meaningful. And with a long pause, though, it was followed by this individual's long pause and a noticeable trace of anger in his voice when he asked her, well, I have a problem with that, what you just said. Why would you call yourself a person of color? Do you feel like you're a racial minority? Is that your logic? Then I'm also a person of color. So this conversation occurred with others around her, but the medical student felt pretty stunned by this person's behavior and began crying. He then said, I'm a Caucasian, and so that would make me a person of color. You're not a minority, and you should never think of yourself that way. God created us all to be equal. So this whole experience, as you can imagine, was uncomfortable for her, and he sensed though there was something wrong in what he said, obviously because she's crying. And then as a way of sort of, I think, kind of trying to assuage the situation, well, my daughter's married to a Chinese person, but I don't have a problem with that. I worry about their children. I worry for their children. I'm not racist because I don't see color. She could have married an African-American man, and that would have been okay. He then said, I can see that I have upset you. He then is told by her that he needs to leave. Later, he asked another medical student about the encounter with him, and he sees that this medical student's name is Tron, and he says, Tron, that's Vietnamese. And you don't call yourself a person of color, do you? The medical student who was the target reported that she was uncomfortable with listening to him, so she cried in front of everyone. The medical student was obviously most upset that her classmates that were there around her at the time, but they didn't say anything about the situation. She went on to say, it was very obvious that I was upset. So hearing that, we could transition to the next slide, Samuel. I've got several questions I'd like to generate some kind of discussion about here just briefly. How would you respond to this circumstance? And what would your next steps be in addressing this situation? I don't know if the mics are muted for everyone, but it'd be great to have that happen if that's not already occurred. How would you respond to this situation, and what would your next steps be in addressing this situation?
Hi guys, I'm Cheng. I'm next to Sam right now. We're just sharing a computer. Um, I don't know. I feel like the medical student was definitely put in a really awkward spot by the person who she encountered. Because not only is this like this encounter very public to other people, it's a very like sensitive topic for some people. I think for me personally, I think I would have, it's really hard for me to be like outspoken. So I think I would have either confided in the Office of Diversity from my medical school, or even asked like my friends who, if they had like a similar experience, see how they handled it, and just try to find solidarity with my peers.
Okay. Anyone else?
I think from like the classmates that witnessed the incident, I think it'd be appropriate for them just to ask that student if they're okay. And if it's pretty clear that they're upset, then just check in with them.
Okay. Very good. Any additional steps that would be taken in addressing this situation? So just a couple things to think about with respect to responding to these things when they occur. They are unfortunately not uncommon. And so what you have to think about, first of all, when this occurs, if you're in the target of this, is am I in a safe place before I respond? So is it safe for me to sort of give a response the way I would want to sort of handle it? If that's the case, then obviously you can direct this person to that this is not the nature of my topic, and we need to move around it. So for the target's position, that point of being able to determine, are you safe, and then take assertive steps to redirect. And later on in the slides, I've got some information about what can be done, steps that you can take. And one is asking clarification. Did I just understand you correctly? Did you just say, are you a person of color, and that you believe that God thinks it's okay to, I mean, in your mind, to sort of justify you saying these things to me, which are basically a cloaked way of being racist? You know, you could say that if you wanted to, if you felt comfortable with it. Otherwise, the other thing, if you're in a position of the observer, you can offer support to the target. So you can offer support to the person who's having these microaggressions or biases directed at them. So if nothing else, you can support this person, let them know you're there, you heard what was being said, and this in itself can be very affirming for that individual. So let's go to the next slide if we could, Samuel, because I know I'm running out of time here. So here again, options that you can do and exercise during that time: ask for clarification, get more information, acknowledge the feelings behind the statement, and which in this case would be, it sounds like you're really hostile toward people of color. And I'm thinking in my head, where do you get off being the person who determines how I should define myself as a person of color? What gives you that right? But again, it's an example of privilege that some people operate from. Separate the intent from the impact. You may be thinking that you were well-intentioned when you said this to me, but it had a negative effect on me, okay? And so these are important things to do. Obviously, you can express feelings. This is a stereotype, by the way, that you're talking about. When you say you don't see color, who actually believes this? Okay, obviously you do, okay, but most people don't that are informed about what happens in the world today. Appeal to this person's values and principles. Obviously, if you say you're a person of God, and one of the things that we seem to be consistent with someone who claims to be a person of God is that you never want to do something that would hurt someone. And in this case, what you've said here is very hurtful. And so that's also another way of sort of getting at trying to get this person to put themselves in the position of the person who is the target of these unwanted remarks or comments. Samuel, could we go to the next slide, please? So I'm ready to ask if there are any questions, and then turn this over to this great panel of people that are here with us tonight.
Okay, well, thank you very much for that great presentation, Dr. Johnson. I know I definitely learned a lot more about bias. And now, if you guys want, we can start the panel if you panelists are ready. And then if you guys just, the people who are not on the panel, start thinking about questions that you guys have, since we all learned a lot more about bias. I'm sure that everyone has a lot of questions. So if you guys want to introduce yourselves, Dr. Raj and Dr. Chambers. I think Dr. Correa is not here right now, but if you guys want to just introduce yourselves and tell us a little bit about yourselves and your experiences with bias in the healthcare field, then you guys can go for it.
I guess I'll go first. I am jayaraj, and I am here on the Phoenix campus. I'm a general internist, and I'm also the residency program director. I've been here in Phoenix practicing for, I think, 27 years. I've lost track because it's been a really long time. But, you know, unfortunately, I think I can relate to the examples that Dr. Johnson gave in his presentation. And I also know many students and residents who have also been targeted by patients in particular for, you know, one reason or another, whether it's, you know, being a woman. So, you know, oftentimes patients will kind of mistake a female physician or a female student or resident for a nurse or another healthcare professional. They might say inappropriate things, such as what Dr. Johnson was saying in his example. I've had patients tell me that I don't look like a doctor, you know, again, for whatever reason, and I'm not sure what their picture of a doctor is, but for some reason they felt compelled to tell me that I did not fit their mental image of what a doctor should look like or be like. And I've had patients ask me, you know, repeatedly where I'm from, where I went to medical school, how long ago I graduated, you know, things that they don't typically ask all their doctors. So, you know, they sort of interrogate me. And when I tell them I'm from New York, they often say, no, where are you from originally? Or, you know, I had a patient ask me, no, where are your people from? And so, you know, I had to say, again, with emphasis, New York. But I think, you know, many of these incidents, like Dr. Johnson said, some are unintentional and just require, you know, a challenge to the patient, back to the patient, or, you know, I think asking for clarification and asking them, well, you know, you just asked me when I graduated from medical school or where I went to medical school, you know, why'd you ask me that, or something like that, you know, just to kind of put it back on them. I think also if somebody says something very offensive and very hurtful, usually that's not an accident. Sometimes it can be intentional. And then in that case, if you feel comfortable challenging them, then I think it's definitely appropriate to stand up for yourself. Obviously, you don't want to get into an altercation with a patient, but I think it's perfectly fine to stand up for yourself, assert yourself, tell them who you are and what your role is in their care, and why it's important that they be, cooperative with you and collaborative with you and communicate in a way that's appropriate, so that you can provide them with good care. I have also been in a position where, I have not necessarily witnessed bias against, students or residents, but I've had students and residents tell me about things that have happened to them. Again, very similar to the example that Dr. Johnson gave. But sometimes the bias comes from, or the microaggressions come from peers or attending. So I recently had a student tell me that she was on rounds with her team during one of her rotations, and the attending on the team started making fun of her name and told her, well, you people have such difficult names. I can't pronounce your name, so I'm just going to call you, blank, and just made up just kind of like a silly nickname to call her, and didn't even really bother to learn her name. And so in that example, after, this had happened, she did what I thought was very appropriate, which, she didn't feel comfortable saying something at the time, which is totally okay. Many times we're taken aback and, it's an awkward situation and maybe we're surprised and we don't think of something to say at the time. But she went to somebody in authority. In this case, it was the clerkship director, and talked to the clerkship director, and the director then address the situation with the attending and whomever else was, saying these inappropriate and very hurtful, offensive things. And so I think that was absolutely the right thing to do. Ideally, if there had been peers or witnesses, they would have stood up, for her. But I think it can be very, very difficult when you're a student or a resident and you're in a position where you don't feel empowered to say something. Well, that's where I think it's really important to go and talk to somebody, somebody in authority or an advisor or even just peers, just to, get that, have somebody validate that what you're feeling is not abnormal and you're not being oversensitive, and what that other person said is not okay. So I'm going to kind of leave it at that for now, and I'm going to let Dr. Chambers share her wisdom.
Thank you, Dr. Raj. So I'm Dr. Chambers. I'm the Assistant Dean of Admissions here on the Phoenix Regional Campus, and I'm also an OBGYN. I have a unique perspective in that I am an international part of the team. I'm originally from Toronto, where we have a very multicultural experience. And so I sometimes think that my experience and my perspective is a little different than most. But I would tell you that regardless of that, I'm not devoid of similar experiences. In fact, many of the experiences that Dr. Johnson mentioned, I've seen or experienced many, if not all of them. I would tell you that I would call out a few things that really spoke to me. And one is the safety of the situation that you're in. I would say over time, as a physician and an attending, as you progress through your career, that safety becomes something that you own. I now create my own safe spaces, but that comes with authority. And I think as you progress through your career, you'll find that to be true too. I am less likely to impose intent and more likely to, though I don't think I'm confrontational, I'm more likely to ask those probing questions like, tell me more. What are you thinking when you ask me that question? Because I do think sometimes we do assume intent when it's not always there. And sometimes it's there. And when it's there, it needs to be confronted and addressed immediately. There's some things you just have to address immediately. I think of some of the various experiences that I've had, much like Dr. Raj. I remember when I first got out into practice, I think it was more often than not, people asked about, where did you graduate? And you're the doctor. I got a lot of that. I get less of that now, I think, because I look older. But responding to those questions at times felt awkward and uncomfortable, and less so now because I think I've learned to be comfortable in my own skin, asking the why behind their questions and probing more. I've had difficult situations where our entire team, when I was at University of Michigan, I came on service one night and the entire team was people of color. And the first thing I heard in board report was that we had a patient who was from the Upper Peninsula who was a white supremacist and had swastikas and did not want women and did not want these people caring for him. And I thought, well, great, this is a perfect team. And so we decided, and as the leader of that team of care providers, I made the conscious decision to go in and have a conversation with this family up front. And I told the significant other, who was the one who was probably the most vocal, that this is the team and we're here to care for you. And we're going to care for you despite your views, values, whatever the case may be, and we're going to provide excellent care for your wife. And that we expect in exchange the respect that would be given to anyone else who would care for him in the same situation. And we brought the whole team in so that there would be no surprises. And actually the experience went far better than I think we could have ever imagined. And he was very grateful. And I thought at the end of it that maybe we had some small part in changing his perspective on how he saw the world. I don't know, but I know that it was critical that we, one, put up a concerted effort to let them know what we would tolerate and what was unreasonable, but also to face whatever ignorance might be there and speak to it. And